Good afternoon, everyone, and welcome to today's webinar. At this time, let's hear from our nurse consultant for Well Ahead Louisiana, Tanya Kyle. Take it away, Tanya.
Good morning, everyone. Welcome to our webinar. The title of today's webinar is Education and Training in Cervical Health Awareness. And so I want to start by introducing our director of our bureau, Dr. Nancy Lowenthal, to give you a welcome, and then we will go from there.
Yeah. So good afternoon, everyone. As we recognize Cervical Cancer Awareness Month, which underscores the importance of women's preventative health, importantly, the Louisiana Department of Health Office of Public Health Well Ahead's own Wise Woman program promotes well-integrated screening and evaluation for women across the nation. The Wise Woman program is an extension of the Louisiana Breast and Cervical Health Program to expand preventative services being offered to women supported by the Louisiana Breast and Cervical Health Program. The intent of the Wise Woman program is to provide chronic disease risk factor screening and health education interventions to women enrolled in the Louisiana Breast and Cervical Cancer Health Program, in an effort to provide no-cost mammograms and cervical cancer screenings while also lowering their risk of heart disease and stroke. Our website provides full details on how we incorporate prevention screenings and assessment and care linkages for cardiovascular disease into breast and cervical health programs in the state. At Well Ahead Louisiana, our vision is to reduce the burden of chronic disease and to assure access to quality health care for all Louisiana residents. We work alongside with leaders at key organizations across the state, such as child care centers, colleges and universities, faith-based organizations, restaurants, schools, worksite, and health facilities, helping to create an environment in which everyone can be healthy. We believe that everyone has a role to play in connecting Louisiana communities to a healthier future. We are committed to educating and empowering leaders across the state with actionable steps to move Louisiana's health forward. Again, welcome to today's webinar on cervical cancer awareness, and I'll turn it back over to you, Tanya. Thank you.
Thank you, Dr. Lowenthal. I would like to start by reading our first couple of slides before I introduce Dr. Gillespie Bell. First, we provide a disclaimer. The Louisiana Department of Health, LDH, employees, contractors, affiliates, etc., have no actual or potential conflict of interest in relation to this program's presentation. The content herein is intended for general guidance and not as legal advice. Laws and regulations take priority if there are any differences. Only LDH's Secretary or Surgeon General can give official statements. LDH cannot speak for other government agencies, and if you need legal advice, you should consult a lawyer. The objective today is to drive collaboration throughout the state that connects communities to tools and resources that can improve the health of our residents where they live, work, learn, play, and pray. So without further delay, I want to introduce our speaker today. Dr. Veronica Gillespie Bell is a board-certified obstetrician and gynecologist, has served as medical director, Louisiana Perinatal Quality Collaborative and Pregnancy Associated Mortality Review, Louisiana Department of Health, professor and system medical director of health outcomes at Ochsner Health. So please welcome her today, and we're so honored to have her as a presenter for our webinar. Take it away, Dr. Gillespie.
Thank you, Tanya, and thank you all for letting me be here with you today. For those of you all that know me in my LDH capacity, I'm coming to you today in my OBGYN capacity to talk about cervical health awareness. This is Cervical Health Awareness Month, and so it's no better time than right now to talk about cervical health, talk about where we are as a state, and talk about where we need to be. And if we can have the next slide. So, and we can go into the next slide. So, what do you need to know? First of all, let me just be absolutely crystal clear that no woman should ever die from cervical cancer. Cervical cancer is one of the most preventable cancers. And how often can we say that about cancer? When we think about other cancers that impact women, we don't know what causes breast cancer. We don't know what causes ovarian cancer, fallopian cancer, uterine cancer, but we know what causes cervical cancer, which is powerful. That means that we have the opportunity to prevent it. Next slide. And yet, with that, we still see cases of cervical cancer, not just incidents, but we also see deaths. So in 2022, and this is the latest data that we have from the CDC, in the United States, there were 12,960 new cases of cervical cancer. And that works out to a rate of 7 cases per 100,000 women. Now, in that same time period, looking in Louisiana, we can go back to the slide we were on. Looking in Louisiana, there were 1,078 cervical cancer cases. And so that's 8.9 per 100,000 women. So that means actually in Louisiana, our incidence rate was higher than what we saw for the average for the United States. Next slide. Now, incidence is one thing, death is another. So in 2023, so now this is looking a little bit further ahead. This is, again, the latest data from the CDC. In the US, we had 4,162 women die of cervical cancer. In Louisiana, we had 65 deaths. And again, this is a very preventable cancer. And so we really need to be working for that number to be 0. Next slide. If we look at the trend in the incidence of cervical cancer and cancer deaths, so on the top graph there, you'll see the incidence, and then the bottom, you'll see the trend for the death rate. So since 1999, there has been a consistent decline in the incidence of cervical cancer. So we are seeing lower cases. Lower number of cases, new cases, which is great. The exception was 2021. Can anybody imagine what might have happened that caused our incidence rate to go up in 2021? I'm sure you have already guessed it. We already know this from other data that because of the pandemic in 2020 and the need to shelter in place, and even for providers, we were only seeing urgent and emergent cases in 2020. So a lot of women missed their cervical cancer screening, mammogram, any kind of screening. A lot of women missed that in 2020. And so then we had more cases of cervical cancer in 2021 because we didn't find those cases that we normally would have seen in 2020 of cervical change, where we would have made intervention, we would have intervened before it progressed to cervical cancer. And the concerning thing also is that our cervical cancer screening rates were below pre-pandemic rates, even as recent as 2023. So we really have gotten to a place where we're not doing cervical cancer screening at the rate that we were doing before the pandemic. And so if we're not careful, this incidence rate that we've been seeing go down over time is going to uptick if we don't start getting back to our rates of cervical cancer screening. Next slide. So what do we know? Why do I say that no woman should die from cervical cancer? Well, we know that almost 100% of cervical cancers are caused from human papillomavirus, or HPV. This is a little bit of the history. So in 1979, HPV-6 was isolated and linked to causing genital warts. In 1983 and 1984, HPV-16 and 18 were isolated and found to be responsible for 70% of cervical cancers. And then 1995, the International Biological Study on Cervical Cancer studied the cervical cancer samples from 22 different countries, and they found that 93% of those cancers could be linked to cervical cancer. But in 1999, they resampled all of those, retested, I should say, all of those samples. And they realized actually that 99.7% of those cancers were linked to HPV. And so Harold Zerhausen was the researcher that initially found this link and did some of these studies that you see here. And he actually got the Nobel Peace Prize in 2008 for this. Again, when you think about cancers, and just specifically if you think about female cancers, this is the only cancer that we can say, I know what's causing this cancer. And so again, we know what's causing cervical cancer. Next slide. So if we want to think about the pathway for eliminating cervical cancer, we know that HPV is the virus that causes it. So if we want to eliminate cervical cancer, there are two big areas that we need to focus on, and this will be the crux of our discussion today, is early detection, and that's done through cervical cancer screening, and then prevention, and that's done through the HPV vaccine. When we say early detection and cervical cancer screening, we're going to talk about what the recommendations are. But as I explain to patients, and I'm thinking about this because I'm in clinic today, as I have on scrubs, when I'm talking to patients, the reason that we're doing pap smears and HPV screening, we are trying to find those small changes that are happening to the cervix so that we can intervene through an excision procedure if we need to do that before that progresses to cervical cancer. When we look at those cases of cervical cancer, 90% of those patients have not had a pap smear within the last 10 years. And then the majority of those have never had a pap smear. So as long as we are doing cervical cancer screening, we really do have the possibility of intervening so that those cells do not convert to cancer. Next slide. So when am I supposed to, oh, you can, if you can go back again, when am I supposed to get screened? Okay, that is a question that comes up. I have been practicing OBGYN. I trained 2004 to 2008. So I've been practicing now for almost 18 years. We have changed the cervical cancer screening at least 3 times since I've been in practice. And so it is hard to keep up as a provider, let alone if you live if you're out in the public. If you're a woman, like, when do I come in? How often do I come in? What are they supposed to check for? All of those things. So I'm going to try to break it down. So there actually are 2 different guidelines. For the U.S. Preventive Task Force has a recommendation, and then the American Cancer Society has a recommendation. And I'm going to try to go through these differences. And then also, as a OBGYN, we typically follow the American College of Obstetricians and Gynecologists, who is revising their recommendations because of some new information. So the U.S. Preventive Task Force says that we should initiate screening at 21 years old, whereas the American Cancer Society says we should initiate at 25 years old. I know when I was 18, the recommendation was that you start at 18. So why did any of that change? Well, when we look at cervical cancer and we look at HPV, again, HPV is the virus that causes cervical cancer. 90% of sexually active people have a strain of HPV. It is a virus. So when you're younger and your immune system is stronger, you have the ability to get rid of that virus, and your cervix will heal. Your cervix will not be impacted by that HPV. Or if you have a slight change to your cervix, you can clear the virus and you can clear those abnormal cells. And so because of that, we don't want to do a bunch of procedures on the cervix that can then in the future impact fertility, when if we just leave women in this age group alone, their bodies can heal themselves. So for that reason, that's why the screening moved from 18 years old to 21 years old. Again, difference in 21, 25. Currently, the American College of Obstetricians and Gynecologists recommends screening at 21 to initiate screening at 21. In my practice, that is when I initiate screening, is 21 years old. So when do you stop screening? So societies are aligned with this. U.S. Preventive Task Force, American Cancer Society, ACOG, the American College of Obstetricians and Gynecologists, they all say that you can stop doing screening at 65 years old. Well, why 65 years old? What is the magic number with 65? There is no magic number. It's just that when you look at the bell curve of when cervical cancer happens and thinking about when women are contracting HPV that can lead to cervical cancer, we find that over 65 years old, those women are not contracting new strains of HPV. And so they most likely don't need screening. Caveat. Now, this is what those are the recommendations from the society. But I do have patients that are over 65 that say, no, I still want to be screened. We also are living longer. That means that there are women that are over 65 that are having new relationships. And so we do want to consider that even though this is the recommendation, I think there is a question of, is 65 the right age to stop? But according to the guidelines, that is when it's recommended to stop. How do we screen? Okay, let me also just be clarified. Just because an exam is done with a speculum, that does not mean you are getting cervical cancer screening. What do I mean? There are times I ask patients, I'm going through your chart, when was your last pap smear? Oh, well, when I went to the emergency department, they did a pap smear. They are not doing pap smears in the emergency department. You had a pelvic exam. So it's important for us as women, it's important for us as clinicians, it's important for us as educators to help our patients and the public understand the difference between a pelvic exam and a pap smear. So coming into the office, and we're doing a pap smear, either internal medicine doctor, primary care physician, OBGYN, midwife, nurse practitioner, PA. When we do screening, the recommendation has been from 21 to 65 years old, screening with cytology. So pap smear. So that's when we take the brush and we're getting cells from the cervix, and looking at the cervix that way. That is cytology. And just as a side note, because I think I'm gonna have extra time, it's called a pap smear because of Papa Nicolau. That's the doctor that discovered this. But for example, when I was a resident, we used to get cells from the cervix and we would smear it on a slide, and that is what the pathologist looked at. We now have the technology that when we do that swab to get the cells, they are able to, we put it into a solution called ThinPrep, and then they're able to look at the cells to see if there are HPV changes based on that. And so with the cytology, if it's only cytology, then that is done every 3 years. The new recommendation is that everybody should be instead getting cytology and HPV co-testing if they're over 30 years old. So 30 to 65 years old. Why is this? Again, HPV is the virus that causes cervical cancer. So we don't want to just do the pap smear. We want to see if HPV is there and if it's active. Just as an example for the importance of HPV, if I have a patient and their pap smear is normal, but their HPV is positive, especially for one of the high-risk strains, I still have to do a diagnostic procedure to make sure that they don't have cells that could be converting to cervical cancer. So the HPV test is very important. And if you only get the pap smear, again, that has to be every 3 years, but if it's pap smear and HPV co-testing, then it's every 5 years. The American Cancer Society has updated their guidelines to also allow for FDA-approved HPV testing only every 5 years. So not a pap smear, only HPV testing, which still has to be collected through a speculum. And they are now recommending for the self-collected vaginal specimen for HPV co-testing. And then if you want to click on the next slide, hot off the press, if we can click to the next. Okay, so hot off the press. As I was prepping these slides a couple of weeks ago, HHS released new guidelines through HRSA, which is also for the U.S. Preventive Task Force. They are also now approving a self-collected, so it's FDA approved, self-collected meaning don't come to the doctor, you at home or maybe in the doctor's office, will collect your HPV test from a sample, from a vaginal specimen. And so, again, this can all be very, very confusing. And I'm going to talk about the self-collected test in a little bit more detail. You can go to the next slide. So what the new guideline, the HRSA-supported Women's Preventive Service Guideline that I mentioned came hot off the press, what they are stating now is that patient-collected HPV testing is an appropriate method and should be offered as an option for cervical cancer screening in women aged 30 to 65 at average risk for cervical cancer. And what is an average risk? So this is anyone who has a cervix. They have to be asymptomatic. What does that mean? They're not having bleeding after intercourse or bleeding that we don't know where that's coming from, because that can be a sign of cervical cancer. And they, or they're having screening for the first time, or they have a history of all normal cervical cytology. So if it's someone that's had a history of abnormal pap smears, HPV testing, they are not a candidate for the self-collected screening. And really, this recommendation from HRSA is coming from a group called the Enduring Consensus Cervical Cancer Screening and Management Guidelines Committee. Sorry, there's a lot of words, but this is a standing committee that continues and always looks at new technology, new approaches to cervical cancer screening, to management, to surveillance. And they make recommendations around cervical cancer screening. Just to give you an idea of who all is on this committee, it's the representatives from the American Academy of Pediatrics, the American Cancer Society, the American College of Nurse Midwives, ACOG that I mentioned, the American Sexual Health Association, the American Society for Clinical Pathology, the American Society of Cytopathology. And there's about six more organizations that I won't read to you. But it's a very comprehensive committee that makes these recommendations. And so I think that when new recommendations come, sometimes we're trying to understand, well, where did this recommendation come? Is this a good recommendation? What does this mean? So just to let you know that this society that made this recommendation about that option for the self-collected HPV is a very robust group looking at this information. We can go to the next slide. And so from that committee, these are actually all of the recommendations that they said, because I think it's important to understand not only that self-collected test is for average risk, but what they actually said in these guidelines is that the clinician collected cervical specimen is still preferred. The self-collected specimen is acceptable, but coming in and having the clinician collect that specimen, that is what is preferred. And so that means that as much as we hate coming to the doctor to get our pap smears and our HPV testing, if we have that ability, that is preferred and that is what we should do. But what this means is those women that live in rural areas and can't get to a doctor, or whatever barriers they have that prevent them from getting in to see a clinician, this is an option for them to still get screened if they're in that average risk group. The other thing is that when that self-collected specimen is HPV negative, then we have to repeat testing in 3 years, as opposed to if you come in to see the physician, then the recommendation is repeat in 5. And so 3 years is recommended if we're doing self-collected tests. If that self-collected test is positive for HPV 16 or 18, remember HPV 16 and 18 cause 70% of cervical cancers, then patients do need to come in and see a clinician so they can have a biopsy to make sure they don't have cervical cancer. If it's positive for any of the other high-risk types, then they need a pap smear. And then if it is positive for an HPV that is not high risk, because there are non-high-risk HPV strains, such as the ones that cause genital warts, then we have to repeat in 1 year. And then if someone is in surveillance, meaning they had an abnormal pap smear, then they need to come in to get a clinician collected cervical specimen instead of that self-collected at-home specimen. Again, these are new guidelines. There was a lot in the press about that self-collected test. But I think it's important for us to understand the nuances because, I mean, I could ask any of my friends or any of my patients, If there's an option to be able to do cervical screening and it doesn't involve a speculum, sign me up. But we need to understand who is eligible for that and who is not. Next slide. All right, so moving on from the cervical screening to now HPV. As I mentioned, just to say a little bit more about HPV, human papillomavirus, this is the virus that causes cervical cancer. 90% of sexually active people have a strain of HPV. There are about 70 different strains of HPV, about 13 different strains that are considered high risk strains that are responsible for causing cervical cancer. I get a lot of questions from patients when they've had completely normal pap smears, negative HPV, and then all of a sudden the HPV test is positive. They want to know is their partner cheating? Where did it come from? You can have HPV for years and it never shows up. It is a virus, and so men have HPV. They don't know they have HPV. Nothing happens to men from HPV. We don't know we have it until we have an abnormal pap smear or HPV test. But again, it's a virus that we contract and can stay dormant for years and then become active. A lot of times, that time of being active is when our immune system is suppressed. So things like pregnancy, illness. But there are things that make it come, quote unquote, out of hiding, and that's what makes it show up. And one of the things that we can do to prevent, especially those high risk strains of HPV, is the HPV vaccine. So the HPV vaccine is recommended to children. These are the recommendations from the CDC to be given to children between the ages of 11 to 12 years old, but can be given as early as 9 years old. Since 2006, among young adult women, the infections with HPV that cause HPV cancers and genital warts have dropped 81%. And that's because of the HPV vaccine. Also, since 2006, among vaccinated women, the percentage of cervical precancer, so those HPV changes that are change in the cervix, has dropped by 40%. In countries where they have even higher vaccination rates than we have, such as Australia, they have completely eliminated cervical cancer. They have no cases of cervical cancer. So this is a vaccine that is very, very, very effective at preventing cervical cancer. Next slide. With that, our vaccination rates are variable. Now, this is data from the US. This is not specific to Louisiana data. I do have some Louisiana data to share. But you can see that between 2008 to 2021, this is adolescents 13 to 15 years old, about 60% received 2 of the 3 doses. But looking from 2012 to 2021, that number is still at about 60% if we look at all races. And so we really have not made a lot of strides since over this time frame of making sure that we're getting vaccinated. And then again, the slide on the right is to show us that the vaccination rates do change based on rate. Now, it's not included in this slide deck, but if we're looking just at our Louisiana rate, and this is from HPV series initiation and completion of adolescents 13 to 17 years old, and this is from 2010 to 2025, we have not quite at that, right at about 60%. So we are getting there. But what we can see is a trend over time of going in the right direction. So for example, in 2010, our initiation rate was about 30%. Our completion rate was about 20%. As of 2025, that initiation rate is about 80%, 76.8%, and our completion rate is about 60%. So on par with the rest of the US. We took a little dip in completion rates 23, 24, and 25. And if we look at that based by urbanicity, so living in an urban area versus a rural area, we have a much higher completion rate in our urban areas compared to our rural areas. And then if we look by race and ethnicity, was actually surprising to me. Our rates are the highest for our adolescents, 13 to 17 years old, and our non-Hispanic Black population. We do have disparities across the state. Traditionally, when we look at data around vaccinations, the rates are usually the lowest in the non-Hispanic Black population, but for us in Louisiana, 13 to 17 years old is actually the highest. Next slide. So what barriers do we have to cervical cancer screening? So we've talked about cervical cancer screening. We've talked about the vaccine. We're going to talk about barriers for each of those. So barriers for cervical cancer screening. Sometimes it's financial. It is required under the Affordable Care Act for all insurance plans to cover cervical cancer screening, but that does not apply to plans before September 23rd of 2010. And so sometimes there are financial barriers to getting cervical cancer screening. And then we also have our social determinants of health, our social barriers. So lack of transportation. That's especially true if you live in a rural area where you may have to go to have your cervical cancer screening. It may be a barrier because of the distance, in addition to having a lack of transportation. Lack of childcare. If you don't have childcare and not able to bring your children into the office, and and thinking about you may not want to bring your children into the office for this visit, that can be a barrier to care. Also, having to take off time from work, especially for our hourly wage workers to come in to see I'll just use an example, to come in to see me. I mean, that's an hour to come in of actually travel to wait for the appointment. That's another hour to then come in to be seen, to then be able to leave, and then another hour. So you're talking about 3 hours for a 15-minute appointment. And so that is a lot when you especially are an hourly wage worker. And then lack of knowledge. There is a lot of misconceptions about, again, the difference between a pelvic exam, a pap smear, why I need a pap smear, how often I need a pap smear, what is the pap smear checking for? Lots of misinformation around that, and just lack of knowledge. And so that is also a barrier to cervical cancer screening. Next slide. So common objections to the HPV vaccine, and you can click one at a time as we go through. So when we're talking about the HPV vaccine, we're typically talking about vaccinating children, and ideally before they are sexually active. And so questions we commonly get, well, why does my child need the HPV vaccine? Next click. Also a question, why do boys need the HPV vaccine? And again, men have HPV, they don't know they have HPV, but them having HPV is how we get HPV as women. And so when we can vaccinate our sons, then that helps reduce the risk of cervical cancer in women. Next click. Why do they need the HPV vaccine at such a young age? Again, it's trying to make sure that we're given the vaccine to build up immunity before they are sexually active. Next slide. What diseases are caused by HPV? And we've talked about this. The high-risk strains lead to cervical cancer. The low-risk strains can lead to genital warts as well as oropharyngeal cancer. Next slide. How do you know the HPV vaccine works? We've already demonstrated that. Next click. Is my child at risk for HPV? Again, 90% of sexually active individuals are at risk. So while a child may not be at risk, we are trying to build up immunity so that they are not at risk once they are sexually active. Next slide. I'm worried that getting the vaccine will make my child think that having sex is okay. And again, these are common objections that we hear in the office. Being vaccinated is certainly not permission to have sex. It is not advocating for sex. We do advocate and teach abstinence for our adolescents, for our younger individuals, and so this is not advocating for that for sex in any way, shape, form, or fashion. Next click. Would you give the HPV vaccine to your child? My answer is yes, and he has been vaccinated. Next click. And then I'm worried about the safety of the HPV vaccine. Is it safe? It is very safe. It has been on the market now for more than 30 years. And it is overall, it is safe with low risk of side effects. Next slide. And then just a testimonial, just to think about why cervical cancer screening is important, to think about why the vaccine is important, and I put a face that we might not think about as someone having cervical cancer. I think there is a little bit of misinformation about HPV, and I know for my patients, they feel like, is there something wrong with me? Am I dirty because I have this virus now? Again, 90% of sexually active people have HPV. So to hear about Patty's story, Patty says, I am a retired New York police officer. I reside in New York City with my husband of 22 years. I am also a 12-year cervical cancer survivor. 3 months before my retirement, I started bleeding between menstrual cycles, and I accredited it to being stressed since I was getting ready to wrap up a 20-year career. She was getting ready to retire. At the time, I had not seen a gynecologist in 3 years. And why was that? Well, my gynecologist had retired, and I didn't look for a new one. I didn't feel the dire need to find one since I felt fine. I had no symptoms whatsoever. I had been married for 10 years and I was in a monogamous relationship. However, the progressive bleeding, fatigue, bloating pushed me to see a doctor. I went in to see a new gynecologist where she took a biopsy, which came back inconclusive. She told me she needed to refer me to a gynecologist oncologist. And when I went to the oncologist, he took another biopsy, and those results revealed that I had cervical cancer stage 2B. My diagnosis has made me a passionate cervical cancer advocate, especially for Hispanic women or Latinas who have a higher risk for cervical cancer. And cervical cancer can be prevented. We have the tools to do the screening, education, and vaccination. My message to women is that we put ourselves to the side most of the time, and we need to adopt a mindset that ensures that we are making ourselves a priority. I mean, how many of us can say that? Health is a big priority for me now because without it, not a lot of things matter, like being able to help my loved ones. With this mindset, we can close the door to so many illnesses. We all have to take care of ourselves because health is wealth. And we can go to the next slide. So in summary, cervical cancer is preventable through HPV vaccination. Early detection through cervical cancer screening can reduce the rates of cervical cancer. And we now have additional ways to screen for cervical cancer, especially for those who have barriers for coming into the healthcare system. There are barriers to both HPV vaccination and cervical cancer screening that must be addressed on an individual and system level. And next slide. These are all of my references, and then we can go on to the next slide. And if you have any questions or you need more information, this is my email address at LDH. Again, I'm doing this presentation today, not in my role with LDH, but as a healthcare provider. And so the other way to get in touch with me is bgillespie@ochsner.org. And I believe I'm going to turn it over to Tanya that will walk us through our question and our webinar section, or questions from the webinar.
Thank you, Dr. Gillespie. That was wonderful. I want to apologize. I cut your introduction short at the beginning. And so I would like to just give the complete introduction for her today. You've seen how passionate she is about what she does. And Dr. Veronica Gillespie Bell is a nationally recognized obstetrician, gynecologist, women's health expert, and public health leader whose work focuses on improving health outcomes for women across the lifespan by transforming clinical care, health systems, and policy. With deep experience at the intersection of patient care, quality improvement, and health equity, her mission is to eliminate disparities and make women's health care safe, effective, and more responsive to the communities it serves. And we can certainly hear that and see that reflected in what you shared with us today. And so now we have come to our Q&A segment. Just a little word of instruction. We already have one question dropped into the chat, I believe, but for all medical questions and or advice, please consult your physician. Feel free to drop questions in the Q&A box and you will be acknowledged by one of our team members. So I did see our first question, Dr. Gillespie Bell, and this was what the first question was. Let me get back to it. Okay. If an adult was diagnosed with genital warts in their 20s, are they at a higher risk for cancer, cervical cancer, in their 50s and 60s?
It's a great question. So let's to before I answer that, let's kind of back up and do a little bit background. So genital warts is caused by, or our genital warts are caused by the low risk strain of HPV. 6 and 11 are the two most common types for causing genital warts. Cervical cancer is caused by the high risk strains of HPV. Again, HPV 16 and 18 are responsible for 70% of cervical cancers, but we have many other high risk strains, 31, 33, 45. There's like a bunch of different numbers. So if someone has genital warts in their 20s, that means they contracted the low risk HPV. So they are not at increased risk for cervical cancer just because they had genital warts. So it would be the high risk strain that would put you at risk for cervical cancer.
Thank you. Okay, Dr. Gillespie Bell, the second question in the chat was, I learned that women can get the HPV vaccination up to the age of 45. Does this apply to men also?
So great question. We didn't talk much about how far up you can, how old you can be to get the vaccine, which has changed. When I was in the beginning of my clinical practice, we only were doing the HPV vaccine up to 26, but it has changed now and it is safe and effective for women and men up to 45 years old. And which is important, I think, for us to understand. And just a few other things about the vaccine, kind of related to this that I didn't discuss, but just in case we're thinking about it. Even if you have a strain of HPV, you are still a candidate for the HPV vaccine. You may have a strain of HPV, but you probably don't have all of the 9 strains that it protects you against. And so you are still a candidate. And there's a little data that shows even if you have a strain of the HPV, that getting the vaccine may help prevent that strain from progressing to cervical cancer.
Great, thank you. Okay, next question. Have HPV vaccination rates been affected by the increased vaccine hesitancy in our nation across all vaccines?
So I think that's a great question. We don't know yet. So the latest data that I was showing was really only through 2021. And then the Louisiana data that I was showing was just a little bit beyond that. But I think we need a little bit more time to see if the vaccination rates are going to decrease for HPV as we are seeing other vaccination rates decrease. My guess is that yes, that we will see the rates decrease.
Thank you. Next question. In your line of work, how would you deal with misinformation on HPV and vaccinations? And how does that show up with the numbers of those who are diagnosed with these cancers?
Yes. So when I have, and this is not specific to HPV, but anytime there is misinformation, I always sit down with my patients and or their family and just tell me, like, tell me what you know, tell me what you hear, tell me what you think. And then we just go through the information. I think it really speaks to the importance of having a trusted healthcare provider. I tell this story like a gazillion times, but My favorite coffee mug is one that I have at home, and it says, "Do not confuse your Google search with my medical degree." The reason it is my favorite is because that was a gift from one of my patients. Because every visit, she would come in and she would say, "I know I'm not supposed to Google, but I did. And so I just want to ask you." And I told, and she knew how I responded. That's fine. Google, get information from wherever you feel like information, you need to get your information, but let's talk about it. And so for me to deal with the misinformation is just to ask in a non-judgmental way, like what you think, and then be able to give the facts, and then also allow that patient and their family to make their own independent decision without my judgment. I tell patients that you have to live with that. Whatever decision is made, you physically have to live with it. So who would I be to judge you for whatever decision you make? And so I think just establishing that trust with patients, I think that helps them to navigate through the information as to what is true and what is not true. In terms of how does this show up in the numbers of those who are diagnosed with cancer, I don't know that we have information that has teased it out in that way. For the most part, when we look at the numbers, it's because those that have cervical cancer, or those populations that have higher rates of cervical cancer, it's because of social barriers that they actually are not able to get into the doctor for their screening.
Thank you. Next question. We've got time for these last two questions that are in the chat. I believe there are two more. What is the submission rate for self-collected tests?
We don't know because this is relatively new. It's been FDA approved for a little while now, but we don't have a lot of data. I mean, I know we in my clinic are not, that's not something we are providing. While it is an alternative to do self-collected, there's a lot of logistics that have to be worked out with that. So, for example, if you send in a self-collected specimen, and I'm assuming that it's like Cologuard, so you're not sending it to your doctor's office, you're sending it to the company that is issuing the collection. If it is abnormal, well, then how do you get into the doctor to then do the next part of it? And so there are systems that need to be put into place for how we manage abnormal self-collected samples that are not done in doctors' offices. But I haven't seen any data on that, on the submission rate. Also, currently, I'm not 100% sure that it's covered under insurance. I know that by 2027, it's going to be required to be covered by insurance, but that may also be a barrier right now.
Thank you. And last question. I do not see a lot about HPV prevention. Why is there limited public education available about it, including how it is transmitted and its connection to sexual activity? While I've seen many campaigns promoting the vaccine, there is often less information explaining what HPV is, how it is acquired, and how untreated infections can increase the risk of cervical cancer. The push is to get vaccinated to prevent cancer, but rarely a push to educate on what HPV is and prevention. Why is that?
So I agree with you 100%. That's why I tried to make sure in this presentation I wasn't just talking about the vaccine, but also educating on HPV. I don't know why we haven't seen more education on HPV and exactly what it does. But you're right. Most of the education is about vaccination with a small mention about HPV. But maybe that's a call to action. We are public health. And so maybe there is a need for that, to talk more about HPV, what it is, how it's contracted, and that may actually help the vaccination rates as well as cervical cancer screening. Because I agree with you, there's very little that is mentioned about HPV.
Thank you, everyone, for your questions. And thank you so much, Dr. Gillespie Bell, for this wonderful, informative presentation. At this time, I'm going to turn the mic back over to Dr. Nancy Lowenthal, our Bureau Director, to close us out today.
Wow. I think that there was an amazing segue back to a call to action. So I want to really just thank Dr. Gillespie Bell for, first of all, the overall call to action, and that is for women ages 21 to 65 to actively and follow their cervical cancer screening or pap smears, do that in the routine way that's been set out by consultation with their clinicians. And then the second thing is for all of us to encourage families with preteens to get an HPV vaccination. And we hear you. The questions from the audience were excellent. And that last one in particular about what more we can do, we will take that back to OPH and have a greater discussion about that. But overall, really, Dr. Bell, thank you for your passion, your dedication, and your expertise, which you bring to women's healthcare in Louisiana and to healthcare more broadly. So thank you. And together we can reduce the burden of cervical cancer in Louisiana. We all have a role to play in that. So thank you all for joining today's wellness webinar. We hope you're leaving with valuable insights and practical tools to enhance your well-being. And remember, wellness is a journey. Small, consistent steps can lead to meaningful change. Stay mindful, prioritize self-care, and support one another in this journey. If you have any questions or want more resources, please reach out and stay well, stay inspired, and we look forward to seeing you in future sessions. So once again, thank you, Dr. Gillespie Bell, and thank you, our nurse consultant, Tanya Cobb. And we look forward to hearing from all of you. Thank you.